I'd now like to introduce Mary Foley, our Director General. Mary has been the driver of the largest piece of single funding reform within the New South Wales health system's history. The transparency that is now available through the way budgets are allocated throughout our system and the rigour with which the thinking has been driven by the Director-General in making sure that that is transparent and open and accountable is actually widely regarded around the country as a significant and transformative change in the way healthcare funding can operate. So, Mary.
It's wonderful to see so many here today. I think we've almost got 800 people because we've got about 780 something registered, and then a whole lot of people saying, oh, I forgot to register, but I'm still here. So, and of course you're welcome if you're in that category too. And I think it does show the level of interest and in our 10 months into our major reforms we introduced on the 1st of July, how it has engendered deep engagement within the system, and people have picked up very quickly in a whole lot of different ways as to how these new tools and approaches can be used to achieve the theme of this conference, which is better patient care. I like to say that on the 1st of July 2012, New South Wales Health introduced really the most profound reform in the funding of public hospitals in this state since 1929. And why do I pick 1929? Because that's the date of the first New South Wales Public Hospitals Act. And really, you can pinpoint it's the date when really, in this state, we started having a statewide public hospital system. You have to remember, in the century before and before the First World War, states did public health. They didn't own or run hospital systems. They had a few hospitals here and there. It was really only in the post-First World War, in the 20s and 30s, that the great public hospital systems of this country developed as such. And so from 1929 to 2012, public hospitals have been funded in this state on the basis of annual historical grants or budgets, plus or minus annual adjustments. And really that is the model. And of course those adjustments are made under various parameters, including policy parameters, but also, I like to say, plus or minus successful lobbying. The funding model introduced on the 1st of July 2012, and which we showcased in the first of these forums in May last year, is generally referred to as introducing activity-based funding, or ABF. And as I say, the interest and enthusiasm that the new model has generated in its first 10 months of operation could lead one to think that activity-based funding is the end of reform in itself and largely focused on questions of efficiency, determined against benchmark average or efficient pricing, determined at a state or a national level. Another focus of the reforms, and very much the focus in the media when it was being negotiated through COAG, is that the funding mechanism was also a means to secure a systematic contribution from the Commonwealth Government towards the costs and growth pressures of the state health systems, a very important piece of national reform, and I'm sure Stephen will refer to that later. And indeed, in terms of adopting these methodologies of ABF, 70% of OECD countries have adopted some form of activity-based funding, and 20 of those countries, interestingly, have purchased the Australian DRG system as a basis for acute inpatient funding, such as Germany and Ireland, who have then gone on to, as we're doing, develop more comprehensive ABF systems. However, the theme of today's various sessions will highlight, I trust, and certainly the experience of you here, I know, is that the most important thing about ABF is that it's a tool which links dollars to individual episodes of patient care. And it's about much more than efficiency. And in New South Wales, the other important point is that our new funding model, which incorporates the emerging national ABF model, is a much more comprehensive reform, which I like to describe as a purchasing model, which encapsulates the breadth and totality of what we're seeking to support, not just ABF where it applies to episodes of patient care, and also that it absolutely underpins our devolved model, which fundamentally shifts the role of the department, our ministry, and the roles of each of the districts and the responsibilities that have been placed locally under our devolved model. And so essentially our model is designed or intended, and we're trying to evolve it that way, and seeking your input today, to underpin our key reform objectives and providing very practical tools to support devolution of decision making closer to the patient, evidence-based care for quality outcomes, new models of care, integrated care in hospital and out, and clinical and community engagement and leadership. The model also is, as Rowan referred to, absolutely powerful in its transparency in resource allocation. And it's that transparency which I've attempted to illustrate in this crude diagram that's up on the screen. It's this transparency of the resource allocation which assists us in addressing the challenges we all face here and globally of designing the health system for the 21st century, in addressing issues of access, outcome, service configuration across the care continuum, prevention, affordability, and prioritisation of investment. So let me just run through, recap for us all. I found it interesting to just go through this myself. I hope you find it helpful. What are the key elements of the New South Wales model that was introduced on the 1st of July 2012? As I say, it's a purchasing model, a comprehensive purchasing model based on a transparent service agreement, and we've just put a picture of a front page of one of those agreements. It's a very modest-looking document, but is a very powerful signal of major reform direction. These are public documents, and every single district and network has them loaded on their website, and it took a little while for everyone to catch on, but the media, politics can pore over those websites, as well as our staff, our communities, and see exactly how our resourcing is allocated compared to what I call the traditional model of the black box of funding model. And of course, the block budget allocation is replaced by a budget built up by service streams and using either a price multiplied by the volume of services, patient services being by, or block grants. And we encapsulated that in Schedule C, and I've just got one of the district schedules, a partial piece of Schedule C up there to remind you what that looks like. A very different model where we very explicitly purchase by stream and whatever metrics and tools are available, with the largest part of the budget, admitted patients and ED patients, being purchased by price and volume comprehensively for the first time. Not only that, but we then explicitly approached how do we deal with the inexorable demand pressures that the states face, because we are the default setting in the system. We're the ones who have our lights on, doors open 24/7. We keep everyone safe. You can always come to us if you can't find the service anywhere else, and we'll save you. That's the expectation from the community, and we endeavour to do that. And we're free. And so that creates particular challenges in the overall structural piece of reform. So then within that context, how do we support growth? So we had a much more explicit approach to identifying the growth pressures across the state, and then seeking to organise our budget and our growth funding using weighted patient volumes and demand modelling to distribute that growth, and to do so very explicitly. And so really, in creating Schedule C, once we had negotiated with you that volume and plugged that number in, the rest of Schedule C pretty much came from the rules of the funding model, which is a total change from budgets where the allocations were fairly arbitrary, albeit based on particular policy imperatives and so on. And the funding of Schedule C was then populated based on districts' own cost data. Now, we knew there were limitations around the initial data sets, but essentially then we landed in a place where the budget's added up to a comprehensive budget, and that all districts received real growth ranging from 2.9% to 6.8% tied to demand, and we explicitly purchased 30,000 additional admission-weighted patient episodes and 50,000 additional ED attendances. As I said, the model is not just a reimbursement model, it's a capped budgeting model, and where services and what's expected to be provided for the funds allocated are clearly specified. This is still an area where it's in development. We don't want to specify to micro level because, of course, the decision-making about how to organise the resources is a local decision to local need. But we need to, but for the first time, rather than having the mystery black box, we also had not only how was the budget put together related to clinical services, but also the range of clinical services to be provided. And Schedule D spells that out, an area where we can have much further refinement, but I've just selected one there from one of the service agreements, and for instance, for statewide services such as ICU units, explicitly stating the expectation and service level. And if we were funding another ICU bed, that's explicitly purchased in the model. Importantly, while the primary means of purchasing were the price and volume using the new ABF tools, particularly for admitted and ED, we've also used other purchasing methodologies. There's lots of different tools that are available within a purchasing model. Of course, we've had block grants, but also we looked in terms of purchasing volumes to bring in a quality measure, and that was in terms of negotiating volumes. We had regard for where the districts had very high readmission rates above state averages, to put discount factors there and explicit objectives about achieving targeted reduction in readmission rates, which is a whole proxy for getting a whole range of service design things right. We explicitly purchased a whole range of an increased number of compact packages, which we've brokered with the NGO sector on a standard pricing model, and which allows you to use at your discretion to discharge a patient who could otherwise be discharged except they need some form of home support. Could be meals, could be help with showering and dressing or whatever. We put in specific service targets for things such as hospital in the home and the chronic disease management program. And we also made specific allocations where new facilities were opening, statewide service allocations such as ICU beds, explicitly identified the quantum for the state's commitment, state government's election commitments around numbers of nurses. The approach also includes a clear performance framework with KPIs under the headings I've listed there, and a clear structured monitoring and engagement process with districts around their performance. And all of you who are part of districts, I'm sure, are very familiar with that regime, which we wholesale appropriated from Victoria, but it's and adapted for our purposes, but it's a very useful model. We also recognised that year one was a transition year. Its primary objective was to convert to the model while keeping the system safe and operating. And this was achieved by the use of transition grants, recognising that there were many imperfections in the data, such as undercoding, anomalies in overhead allocation, cost classification and data capture, especially in outpatients, which is still an area where we need to improve our data, but are making progress. And we also had clear requirements for clear turnaround plans from districts and networks who'd had budget overruns in the tight budgetary environment. And in implementing the model, New South Wales fully embraced the IPA-ABF model. Because we were whole de novo adopting this model, we didn't have to abandon some other model. Victoria stuck with its WESAs in the model in its first year, whereas we went straight holus bolus to the national model using national weighted activity units. And we were also the first state or territory to actually direct funding through the National Health Funding Body on the 3rd of July. So we actually jumped in boots and all, with, as I say, those sandbagging things we did to keep the system safe and operating while we did so. So 10 months on, how have we fared? As I said, there's been rapid development at the statewide and district level. I've just put up there as an illustration of that 2 of the screenshots from the clinical phone app that the Sydney Local Health District has developed. We said to Teresa she might need to put a booth outside if people want to start buying it from you. Just by way of illustration of the sorts of innovation and energy that this has generated. But the things we can observe are rapidly improving systems and tools, both at the statewide level and at the local level. At the statewide level, for example, collecting the data collections from you, cleaning those up, getting them consistent and submitting them to IPA. Nationally, it was a 3-month process. We now do it into a portal in 24 hours. So we have all our data with IPA, well ahead of, I gather, any other state or territory. Much better understanding and management of costs, and we have turnaround plans that were set at the beginning here being achieved, and we are predicting an overall on-budget performance. Even more importantly, there's strong evidence emerging of considerable clinical engagement and, even more importantly, leadership. It provides a basis, this explicit and transparent approach, for participation throughout our health system in budget and resourcing deliberations by districts. But also people are using the ABF tools to provide clinical feedback to individual clinicians about management of patient treatment, and that's probably the more profound effect. It's also created more clarity around the demand pressures and the resource allocation challenges at the district level, how to meet the demand, but at the same time, how to build the services that will help to moderate that demand and provide a better patient care model. I think having the more transparent information in this regard has helped to support the collaboration that we're seeing between local health districts and Medicare locals to integrate the patient journey. And we're certainly seeing the ABF tools being used to better understand resource impacts of new models of care and reductions in unwarranted clinical variation. Because to the extent we achieve those things, it flows through into the costing and the pricing and the volumes and the trends in those things. So what's in store for 2013-14? And I know a lot of you are very anxious to hear where we go from here. So, year 1, a successful transition process, we're all getting the hang of it. What's next? In terms of the national reform structure, this is another transition year in that the Commonwealth is committed to its current level of funding, and the growth funding commitment tied to the growth in demand in each state happens from the year after. We're also, given the timing of this meeting, ahead of the federal budget, which is on Tuesday, 14 May. And the state budget, which is 18 June. So we've still got a few of the parameters at play. In the federal budget, of course, we're interested in seeing where we land on some of those national partnership agreements, so we can then work out our purchasing model, depending on what's going to happen there. But in terms of the things that we can talk about today, the national weighted activity units have been fine-tuned by IPA. Which is a good thing based on feedback. However, it also means that you have to rebase this year's numbers to be able to compare them with next year's numbers. So, for instance, our state efficient price using the previous NWAR model, as you know, was $4,471 per weighted NWAR, and the rebasing using the new parameters would mean that'd be $23 less if we were using it in this year. So that'll just add some challenges when we're trying to do last year's budget, this year's budget. And those adjustments in areas such as paediatrics, a lot of feedback about that area, and changes have been made there. Weightings for indigeneity and remoteness and ICU are some of the ones, and there's been some DRG by DRG refinement as well. The biggest single change will be we'll be moving from block grants for admitted mental health, acute and subacute, and subacute generally, rehabilitation palliative care, in the new model. That will make a significant change. And also it was developed a new approach for standardising block funding of small hospitals. So we'll start to have some benchmarks around the block funding as well, for those, particularly for all those country hospitals. Just to show you what that means, it shows the proportion of district budgets that were done under an activity-based funding model this year and the proportion moving to next year. We still have the non-admitted mental health and subacute in block funding. And if you want to see how the ABF splits in terms of combined district resources, clearly we're dominated by acute admitted, but I think the non-admitted, including outpatients, it's interesting to see that that's the next biggest area, not ED, even though it's admitted and ED that we tend to focus on with the most sense of urgency. And then we've got subacute and mental health starting to come into play. The biggest area we're developing the purchasing model in is actually how we purchase activity and having activity targets. And we're looking at how we go beyond just the immediate demand pressure, which we used this year in modelling trends in each district and hospital, to bringing in weighting factors that relate not just to demand but to quality, right setting for the patient, equity considerations. I won't go through all the detail here, but just to give you a taste, and these numbers have gone out to districts. We're in the process of discussion and negotiation about them. We're using the 5-year linear extrapolation, which we used this year, but we're also adding to that weightings against weighted population change, unplanned readmission rates, preventable hospitalisation, relative utilisation rates and health need index, which brings in equity and access considerations. So they're specific adjustment weighting factors on purchasing volume increases. And then also additional considerations in negotiation with districts. We'll be looking at inter-district and cross-border flows and specific capacity changes. So if you've got a whole new service where a new capital facility has been built, then we'll be obviously purchasing the services to populate that too. I won't go through the detail of all of them, but a similar approach with a more refined approach on ED. And with mental health and subacute, I won't go into the technical detail now, but they're essentially the ABF basis of both of those and mental health's an interim model. The subacute is based on the New South Wales developed SNAP model, is more bed day based. And so therefore you're really funding capacity. And so that forms the base of the funding. And then we're allocating growth according to where we're purchasing new capacity. So to the extent we're opening new subacute units in the forthcoming year, new mental health units, we will explicitly purchase using the new model. Non-admitted, still the most difficult area, but we've made huge strides in the last 10 months of improving the data. We've created a conversion ratio to move between our occasions of service model and service events by district, because every district sort of has a different array and way of doing things. And where we can, we're looking at a weighted population growth to patient level data. But again, this is an area where we're proceeding with extreme caution until we get the data better. But as we're finding, the more you use the data, the better it gets. So just to draw it to a conclusion, and we're still going to need some form of transition grants, and we're looking at how we might structure those. We're looking at having a transition grant in relation to all streams, ABF streams combined, but probably a separate one for mental health, given that's an area of specific government commitment around funding, and also it's an area where we're very keen to explore and unpack how that works. This is the slide we used last year to just show the different pricing by district and where the different districts stood in relation to an average state price related to acute admitted and to emergency department. And I'm sure each district's quite familiar with where they sat on that range. And for many, it was a surprise where they sat necessarily. Those who had costs above the line, of course, had transition grants to maintain their level of funding. We said that put people on notice, people had to understand their funding, understand what those transition grants were for. A great deal of work has gone on, when we put that all together and used the larger ABF, this is looking at cost yet, we haven't priced, the spread is actually quite radically different. In fact, Far West, for all sorts of good reasons, went from being the cheapest to the most expensive, but that reflects its particular service challenges and the significant service and cost components it has outside the acute setting. And there's quite some other radical shifts we find with this model. We've got more convergence to the mean, which is what systems generally find when you introduce these models. That comes from improving the data, improving the coding. It also comes from districts have been working hard on their performance, so we've had some really impressive turnarounds in terms of financial management related to strategic resourcing of district services. And also, now that we've got a larger pool of the resources in the mix for ABF, the overheads are better captured and applied across the service stream. So it's quite interesting to see how that plays out. So we're still looking at, given all of this newly emerging information and the quite big shifts, how we, in this second transition year before we go the full Monty in 14-15, as to how we approach that. And we're interested in feedback, ideas. So just to conclude, the New South Wales funding model is about a lot more than activity-based funding, and it's not an end in itself, the most important message. The power is in its transparency of resource allocation and performance of the health service in delivering patient outcomes. It critically underpins and provides a great platform for the things we want to move forward on, and which will be articulated in the middle of this year in the state plan, which has been undergoing a state health plan, which has been undergoing a widespread consultation process around the state. Supporting our devolution agenda, which again is not just a philosophy, it's about better patient care being able to be organised locally. And strategic resource allocation, as I say, to design and deliver the health system we need for the 21st century. So what now? For today, I'd really like to ask you to join in and contribute to the emerging reform model, particularly through the workshop work, and also to commend the model to you and to continue doing what you're all doing, and that is to apply it locally, because as we cascade this model deeply into our systems, it is very, very empowering, right down to the individual unit level, in being able to deliver better care for patients. Thank you.